I would like to invite the new set of chairperson, Dr. Kapil Jamwal, Dr. Vivek Raj, and Dr. Kunal Das for the next session. And I request chairperson to start the proceeding. Dr. Vivek, your mic is mute. Dr. Vivek, your mic is mute.
Okay, I'm unmuting that. Actually,
Yeah.
I don't have the agenda in front of me. I was having login problems right now. So if you don't, I don't have the full agenda in front of me. It, hello? Can you hear me?
Yes, we can hear you, sir.
Sorry. No, I don't have the agenda in front of me to introduce everybody. So I would request one of my co-chairpersons to, if they have the agenda in front of them, to introduce. I just got in actually, having connection problems.
Okay, sir. So basically, we have the three very good international speakers, Dr. Vinay Dheer, Professor Miranda, and Madam Pusnavadi. So they'll be speaking on three topics. Dr. Dheer will be speaking on antegrade biliary stenting, US guided biliary stenting, and Dr. Miranda will be speaking on the gastrojejunostomy, and Dr. Pusnavadi will be speaking on pancreatic cysts. So we'll be starting the session with Dr. Vinay Dheer, and who has been pioneer in India. It's a pleasure for me to introduce him because he's been pioneer in India starting the US biliary drainage. And over to you, sir. And it's a pleasure to meet you again.
I actually was having trouble connecting, so thanks.
Okay, good afternoon. Good afternoon, Rajesh, Kapil, Vivek. So nice to see all of you guys.
Yes, sir.
EUS guided antegrade stenting. I have to show the technique. I know this technique is not very commonly done. The transluminal techniques are very common, but I personally love this technique. I will tell you why. So as you all know, EUS guided biliary drainage has arrived on the scene. We just heard Dr. Wadhwa, his elegant compilation of the best studies, in which he showed that EUSBD is superior to PTBD, so it should be used as the first rescue option if ERCP fails. And these are some of the studies with large number of patients where you see EUSBD has a good success rate, 90%, and modest complication rate. Most of these adverse events are mild, although serious and fatal events can also happen. There are three randomized trials. This is just one of them comparing ERCP to EUSBD for distal malignant obstruction, and EUSBD has shown to be equivalent to ERCP. So while ERCP remains the procedure of choice for malignant biliary obstruction, EUSBD shows equivalent results and should be used for patients with failed ERCP, patients who have postoperative anatomy and you cannot reach the papilla, or patients with duodenal stenosis. A number of EUS guided biliary interventions are available, and how to choose is always an issue. So the basic philosophy is, if the papilla is available, if there is no duodenal stenosis or post-surgical anatomy, then you should first try rendezvous or antegrade procedures. Both of these are transpapillary procedures. If papilla is not available, you have duodenal stenosis or post-surgical anatomy, then you go for choledochoduodenostomy or hepaticogastrostomy, the transluminal procedures. So these are some of the studies which follow the same principles. You see here, this is what I like from Michel Carlet's group. If there is dilated intrahepatic biliary radicals, you place an antegrade biliary stent. If that fails, do hepaticogastrostomy. If the intrahepatic radicals are not dilated, only CBD is dilated, do a rendezvous. If it fails, put a transenteric stent or choledochoduodenostomy. So that is how we choose the procedures. Now coming to antegrade procedures, it's exactly like PTBD. Only thing is, it is done from stomach. It is not done from the skin outside. So you use an EUS scope, and then you pass a stent which goes all the way across the hilum across the tumor and across the papilla. So it allows biliary drainage through the transpapillary route. And the advantage for me personally is that it allows the routine metal stents that we use for ERCP can be used for antegrade stenting. And so it saves me a lot of cost. I do not have to use EUS specific stents, which are 2 to 3 times more costly. So the advantage is that there are no bile leaks with this, or very few bile leaks. The disadvantage is there are higher rates of pancreatitis compared to the transluminal procedures. So let us see how we do this procedure. Um, so this is left lobe of the liver. This is where our needle comes from. You choose a segment 3. You see these are nice, juicy, dilated biliary radicals. So you have to assess the angle. Imagine in your mind where the needle is going to come. You see the needle is coming here. You do Doppler, find out that there are no blood vessels. Use your fluoro to see that the scope is looking towards the hilum, not looking away, so that when you pass the needle, the wire doesn't go this direction, it goes towards the hilum. Once you have done all this, you puncture with a 19 gauge needle and aspirate bile, confirm that you are in the biliary radical. So this is the first most important step. So your scope has to be in the proper position. Your scope should be fixed in that position. Now, if you see here, this is my scope, this is my needle. It is looking towards the hilum, but I have punctured it in an area where I have to go like this. You see the radical is going up, then turning, it's almost a U-turn like this, and then here is the stricture. So this assessment has to be done simultaneously. You have to know what angles you have to really pass before you can reach the stricture. So this is an analysis you have to do. So you see here we have punctured at the edge here, and then you have to go like this. This is the right side. So it's a communicating block. And then faintly you can see the block here. Because when you pass the wire, all this information is going to be very useful. So this is a segment 3 puncture. And sometimes, if you are lucky, you get a nice radical which is closer to the hilum. So in this patient, if you see here, I am assessing the radical and I am trying to go clockwise, and you see I'm almost at hilum. This is this white area. You can see the artery here, the portal vein here. And you see this is the last part of the left intrahepatic biliary radical. So if you do Doppler and find no vessel here, puncture here. This is better. Why? I will show you. So I punctured here. It is easy. You see the puncture is easy. And then you see the direction here. Your needle is coming like this. So there are no angles, unlike the previous case that I showed you. The wire has to come straight here and then go here. See here, so we are punctured close to the hilum. Previously, we were told not to puncture close to hilum, but I think that is okay. If it's an avascular plane, there are no big vessels, go ahead and puncture. The most important technique that you have learned for antegrade drainage, antegrade stenting is guide wire passage. We use a Terimo 032. Now you see this, I have passed this wire and it has gone in the opposite direction. So you need a steerable Terimo, that is a Terimo with a J tip. Use a J tip Terimo and use your thumb and the index finger to rotate the wire. Like this you have to rotate, and then only about 1 centimeter of the wire should be out at one time. If you push in too much of the wire, it will coil and it may shear. So small amounts of wire need to be passed. Now you see we are rotating the wire, gently trying to bring it back. See now we are rotating it here. I hope you can see this. And then it goes up. See this? It has gone up now. Once it reaches here, you again have to rotate so that it goes in the appropriate direction. And then once you have found this, you you coil it here, bring it all the way down. See, you see how it is rotating? So rotation is extremely useful. And then coil it here, at which stage you have to use your dilator. So now we are safely, securely in the biliary system. So I'm using a 6 French cystotome. I love it. Very, very good equipment. Remember the angles always. When you have to pass it over the angle, your assistant should make the wire a little taut. That will help you. Once you are here, you can inject more and then direct the guide wire in the direction that you want. You see, there is no contrast going here, but the Terimo has found a way and it has gone down. Why? Because the cystotome is in place, which is stabilizing the Terimo. You see here like this, you are into the duodenum. Now you are safe in the duodenum. Now all you have to do is, of course, inject contrast, see that it is in place. Then withdraw the Terimo and place a stiff wire, because you have to place the stent over a stiff wire. So these simple things you have to remember, small things, but very, very important things. So we are placing a stiff wire now and withdrawing the cystotome. In the second case that I showed you, you see those problems are not there. Here you have to come like this. It is pretty straightforward. So once I get this direction, so here if you see, I am using a VisiGlide. I am not using a Terimo. So it's a 025 VisiGlide. See, you have got it into this direction. Once you are here, it should be really straightforward to pass the. So this is a segment 2 kind of passage of needle and wire. You see here, you are here, then you pass your cystotome. Once you coil it here, pass your cystotome, and then you can go straight through. Now this is a benign case, which I am showing you, this one. So see, the cystotome is here. We turn the cystotome down, and then it helps the passage of the wire. You can also inject further to find out what is going on, where is exactly is the stricture. You see here, now the wire will go easily through into the duodenum. So these are simple steps, and we can easily learn them, or your assistant can easily learn them once there is a little bit of experience. So now you see, we are in the duodenum and we pass our cystotome there and replace the wire with a stiff wire. Very rarely you need dilation. Vast majority of cases you don't need dilation, but you can dilate if it is a tight stricture. So here you see even contrast is not going. So I used a Sohindra dilator. I will show you fast. Anything that you are passing, remember this angle. This is a very acute angle. When the dilator will come here, the scope will be pushed back. You should be ready for that. Tell your assistant, please keep the wire very tight so that the dilator goes over it. See here, gently we are pushing it, and you can see the pushing action here. See, my scope is being pushed back here. So don't worry, gently push it. And when you come into the stricture, again the same process, keep pushing gently, not losing the axis, and it goes down, and we can dilate. Once we have dilated, the placement of stent becomes very easy. In the second case, I have used the balloon. You can use the biliary balloon for dilation. See here, this is a biliary balloon. You can use that for dilation. Go across the stricture and dilate it. But these are very rarely required. Vast majority of cases, you don't have to dilate. Okay, my time is up. So I'll just show you the last thing. Once you have a dilated, nice dilated tract, use an uncovered SEMS. Again, this angle, you have to be very careful. Gently, with the help of your assistant, negotiate this bend. Because we have dilated, we will not find a problem here. The stent will go pretty straightforward. Once you are into the duodenum, you have to inject some contrast. Why? Because you need to know where the papilla is. So inject contrast through the stent, and you see here, here is the papilla. This is the papillary position. Keep about 1.5 centimeters here, and then deploy the stent. So deploying is exactly like ERCP, no difference. In fact, the advantage is if you don't like the position because this is a biliary ACMS, you can close the stent and then again deploy it. So deploy it and then you have a fantastic drainage. You see the stricture is here. This is the CA gallbladder and here is the stent fully deployed. You can place a plastic stent here between the left liver and the stomach if you want. I usually never do it. Some of my Japanese colleagues do it. I think my time is up, so I should stop here. Thank you very much.
Thank you, Dr. Dheer. Am I audible?
Yes,
Hello?
yes, Vivek.
Thank you very much. And you made it look very simple. I know it's fairly complex. Will we have questions at the end of the group session, or should we have some questions now?
Question should be now. With each
Okay.
talk, we can have question, and we have still 4 minutes to go for the discussion.
Let me just ask the first question. So from Dr. Dheer. So 2 questions. When you use the cystotome, what is the risk of thermal injury and pain from the liver puncture? That is one question. Secondly, there are, I'm sure, situations where either your wire falls off or you are not able to negotiate the bend. Do you then just leave a stent through the liver into the stomach? And what sort of a stent do you leave in?
So very good questions, Vivek. So cystotome, when it came, there were fears that it can cause thermal injury or bleeding. But after doing so many cases, now we are using it for over almost a decade. 6 French cystotome particularly does
Right.
not cause either bleeding or major thermal injury to the liver. It's very, very safe. So please use it without any problem. And the second question is, in case you fail to negotiate the wire across, yes, hepaticogastrostomy can be done. There is no problem. So you have a salvage, you can do a hepaticogastrostomy if you cannot pass the wire across the papilla.
Because that's a problem many times we face because of the tight bends that you encounter inside. Sometimes you're able to get your wire across, sometimes you're not. So I think those are the real issues.
More
And
often
you-
than not, it's a question of patience, Vivek. I think all of us have it within us to succeed at antegrade, but I think we all believe we have HGS. Hepaticogastrostomy is available. Why waste time? Let's quickly pass a hepaticogastrostomy stent and get on with it.
So what stent do you use for hepaticogastrostomy? Actually, I don't do this procedure yet, so I'm just curious.
Hepaticogastrostomy, there are multiple stents available. There are GeoBore stent, which is available. Then there is Bona stent also available. You can also use partially covered biliary metal stents. There is no
Right.
problem with that. There are plastic stents available in Japan, not in India.
That's what I-
Yes.
It's going to be metal stent, and we basically use the dedicated
Yeah,
stent. Great. Well, thank you so much. Any other questions?
So there's a question for you, sir, from Saurabh Gupta. He wants to ask that with cystostome, and in addition to initial puncture, do you use cautery when you pass the stricture?
That's a very, very good question. So you can use, if you find that it is a very, very tight stricture and you are going through the tumor, you can use it to burn through the tumor. It can be done. There is no problem. It is required very, very uncommonly. Most of the times, if you are through the hilar bend, the bend which is there above at the hilum, once you are through that, the rest of the passage of the cystotome is pretty okay. Just remember, never use cautery to go through the papilla. Then it will be 100% pancreatitis.
Yes.
So, but you can, if you need, go through the tumor by burning through it.
Okay, so if there are no further questions, we'll probably move on. Thank you, Dr. Dheer.
Thank you very much. Thank you.
Wonderful lecture. Thanks. So the speaker, I would like to invite Dr. Manuel Perez Miranda. He's going to talk on how do I do gastrojejunostomy. And again, gastrojejunostomy, I think we had a presentation yesterday also. This is a hot topic, a slightly difficult procedure. So I would look forward to listening to Dr. Manuel.
Okay, sorry about this. US guided gastrojejunostomy. It's a real honor to be at this wonderful meeting, sharing this topic with you. even if it's only over the internet. So before I go into a detailed description, I want to briefly summarize what are the essential steps of the procedure, what options do we have to accomplish successfully each one of these steps, the difficulties, and then I'll go into the steps themselves. So to create a EUS guided gastroenterostomy, we first have to distend with fluid the small bowel. And then we have to be able to identify under EUS from the stomach, insert a stent delivery catheter, deploy the distal flange into the small bowel, distal to the obstruction, on the proximal flange in the stomach, from where we're imaging the small bowel. And this, using luminous metal stents, creates tight apposition of the gut walls and a very stable anastomosis. This is preclinical studies and that have been reproduced in clinical practice over the past 5 years in more than several hundred patients. So for distension, the dominant strategy is the so-called assisted, which is with a double balloon tube system, balloon catheters like stone extraction or balloon dilators, or a nasobiliary drain catheter. So basically, we get across the stricture over the wire. With the nasobiliary drain, we can go through the scope. With the other devices, you have to go through an over tube or over the wire directly, maybe with scope assistance, which makes them a little bit more cumbersome. And then one of the originally described alternative for a small bowel distension is just free instillation of fluid, 1, 2, 3 liters. And that was what Ken B. Muller did to his pigs in the original experimental study. Then we need to be able to identify the small bowel. Again, using fluoro and EUS, this is very safe. We can spot one of these devices or the fluid they contain. Some people find useful to puncture with a fine needle after injection of methylene blue. And then LAMS placement, the dominant strategy is the freehand insertion with intrachannel stent release. The alternatives are over the wire, LAMS insertion with the proximal flange deployed under endoscopic monitoring. And finally, this is the last step, which is not the least important, is we need to be aware there is a definite risk of misplacement in all different varieties, and we need to be able to check for proper placement and address misplacement in case it happens. The dominant strategy for that is LAMS removal and duodenal stenting. So you remove your misplaced LAMS, you close with an over-the-scope clip, and you go away. You don't try to be too brave. Other alternatives are bridging of the track or creating a new track, replacing it with a new LAMS. So recent learning curve studies state that in order to become proficient to do EUS guided gastroenterostomy, you need 25 procedures, and to really become master, you need 40 procedures. I think this is a little bit too exaggerated because these studies were conducted before the procedure was properly standardized. And then you again go to the literature and read these papers, and I underscore that all of these authors here are close friends with whom I've cooperated, but you look at the pictures, you see a balloon dilating CRE balloon filled with contrast here. You see a gastroscope past the duodenal stricture into the third duodenum, trying to create the so-called reverse or retrograde gastroenterostomy. You see a wire entering into the jejunum, exiting through the pylorus to the mouth to create double traction. And when you read these papers, look at these pictures, you just can only think, oh my God, this is not for me. Maybe in a few years I'll be able to do this, but this is too complex. And what we need to do to create a reproducible procedure is to simplify this. So important steps for patient preparation, there's only one. The only one important step is a nasogastric suction to clear the stomach for retained fluid and food debris. That will make your procedure safer and simpler. There are many other considerations that I don't want to go into detail. Antibiotic prophylaxis is not really necessary, but it's typically given. Of course, coagulation need to be in place. Low albumin, as in contrast to happens with surgery, is not an issue. Ascites, if it is mild, is okay. If it's large ascites, we can deal with paracentesis. Most people will be doing this with anesthesia and intubation for fear of aspiration. In fact, if you have a properly sedated patient with aspiration of the lingering fluid, it's not really necessary. So for us, and then some people will say that a surgical consult is indispensable. Well, it is desirable, but depending on your practice setting, it's once the patient is decided for palliation, it's really within the endoscopic realm. You don't really need a surgical consult. And very important, biliary drainage needs to be addressed because 90% of these patients will have either concomitant or prior biliary obstruction. So if biliary drainage is not addressed, during gastroenterostomy is the right time to do this. And the ideal biliary drainage option for this patient is transmural EUS guided biliary drainage or surgical bypass if it's already been done. But transpapillary drainage tends not to be a very good option. So this is my summary, how I do it as regards patient preparation. Just be mindful of coagulation and biliary drainage, do NG suction, but all the rest we don't do. How about small bowel distension and lumps placement? Well, we have these days, this is the standard, in my opinion, the hot Axios with freehand that allows freehand insertion. This is the very first freehand gastroenterostomy reported in the world by the group in Tokyo Medical University. Just look at how easy it is to puncture a nicely distended loop of small bowel. So this nicely distension, of course, there is some catch in this video. This is not gastroenterostomy for gastric outlet obstruction. This is afferent loop syndrome. But if we can achieve the same level of distension, we can do it as easily, just as easily. This is the difference using hot Axios in time between gallbladder drainage over the wire, that is 19 gauge needle, guide wire punction, then hot Axios, or freehand hot Axios insertion. Look, this is 4.6 minutes in difference. This is a whole world of a difference in there. And this is why freehand will result in a faster, more efficient procedure, right? As I mentioned, the double tube achieves in one go target identification and lumen distinction. So there's no mistaking this segment here for the transfer column. When we don't have the double balloon, there are a variety of other devices that have been used, ranging from nodes to balloon catheter or balloon snare assembly. This is all from the old days when we relied on a wire for self-insertion. Now, well, we need the linear EUS, of course, maybe also a forward or a side viewing gastroscope to place the nasobiliary drain, fluoroscopy and electrocautery source. The devices that we use for guide wire passage is the Oasis 8.5 French catheter with a 0035-inch wire. We favor the 8.5 nasobiliary drain over the 7 French 5 nasobiliary drain. We prefer to instill a little bit of methylene, dilute methylene blue with contrast. And after 2 initial syringes, we use the water pump through the nasobiliary drain to create a nicely distended loop of small bowel. And finally, we use the hot Axios. And we have everything ready before we start. And once we have everything ready and line up, this is the Oasis. This is type 1 stricture pylorus. We see the luminogram very easily. This is bulb, second and third duodenum, and we want to go with a loop. It makes very easy to progress the guide wire. It's good to have the wire beyond the trites, and there is where we want our nasobiliary drain looping. So you see here, the nasobiliary drain is looping past the trites angle. Then we remove the echo endoscope. We were doing it with the echo endoscope. You can do with a gastroscope. And then we insert again in parallel with some lubrication. And this is the time when we inject methylene blue and contrast. Our scope is in the stomach, the US scope. We distend the loop of, this is the fourth duodenum and the initial jejunum. And in addition to that, we connect the MB drain to the pump and we step on the pedal. So we get 3 centimeters here, 4 to 6 centimeters here, creates a nice landing space for freehand insertion of a lumina metal stent. So no finder needle, no wire, no hanging around and these 4 additional minutes. We just deploy intrachannel under direct endosonographic view, the distal, and intrachannel the first. And what is the critical step? The critical step is exactly, this is another illustration. This is one of our earlier patients. You see that in this case, we had in place a biliary stent that was embedded into the, you can see here how the biliary stent is getting into the duodenal stricture. That is why it was dysfunctional. And that's the reason why I say transmural, either hepaticogastrostomy or choledochoduodenostomy works better, because eventually if you have 2 stents, one is going to get in the way of the other sooner or later. So this is, even if technically successful, it tends to result in stent dysfunction. So I just wanted to say, so this is the same method. We place the wire through the duodenal stent. This is a 7 French nasobiliary drain. We put it past the triste angle. We distend the small bowel real time under EUS imaging. And you see this is very clearly the small bowel. We can even see under EUS our catheter. So this is, these 2 hyperechoic dots is the nasobiliary drain. So we don't need any finder needle. There's some ascites here, which is, as I said, is not a contraindication. And there we need to go fast and steady, or, I mean, not like a needle, but keep pressing on the cautery until we see the bubbles. If we don't go steady, we push away the small bowel. This is the major risk and the major reason why misplacement happens. So we need to be mindful of that. This is a critical step, and we are not going to make it less likely by using wires or balloon targeting devices or anything. It is just nice distension and steady stent delivery advancement. The other thing that has made this very much easier for us is the intrachannel stent deployment. So you go for the 4th step, proximal flange deployment into the channel, and it deploys here. And once you've done that, we push out from the channel the proximal flange. So how to overcome file guidewire passage? We cannot place a nasobiliary drain. Does it mean we cannot do the gastroenterostomy? Of course, there is the graded injection technique. We spot the duodenum next to the pancreas and their EUS. This is a collapsed small bowel lumen. We first need to use a 20 gauge needle. And then we start injecting not contrast, not methylene blue, just saline. So if we create a bleb, like in this case here, we can, nothing happens. So you see here how on initial injection, the needle is within the wall, is creating a bleb. I'm pulling back, and as I pull back, the needle tip disengages from the wall. We find the lumen, and here's when we distend with saline. And after that, we put a 19 gauge needle to create a nice enterogram, this time already with contrast and methylene blue. And that is when we're ready to go freehand with hot axios. So we remove that 19 gauge needle. Again, no wire, no wasting time around with multiple exchanges, and freehand insertion. And even if we come up with a nicely distended target like this, sometimes the ultrasound window inevitably gets lost in the process. So we're trying to go freehand on this nicely distended target, but somehow we are a little bit tangential. We don't go through fully. We lose our ultrasound coupling, and we end up misdeploying the distal flange into the peritoneal cavity. What are the options here? Where we can fully deploy the stent, create this misplaced stent as a port to entry the peritoneal cavity, or we can identify the perforation with a guide wire, remove over the wire. Of course, this procedure should be done on the CO2. I forgot to mention that. And we use a forceps, rat tooth forceps, to carefully remove over the wire. If the stomach is clean, if there is not a lot of retained solid debris, we're very careful in removing over the wire these misdeployed lamps. There's a little bit of friction at the cardia and the upper esophageal sphincter, but we just pull back while keeping the wire under endoscopic and fluoroscopic monitoring. And then we go back inside parallel to the wire with an over-the-scope device. So we follow the guide wire. We don't need a lot of insufflation here, which is not going to help. And then once we locate the perforation, we can use the T forceps or suction to pull the edges of the perforation into the cap and then deploy the Ovesco, and nothing's happened here. Nobody will know the wiser. I mean, patient will not notice anything. There won't even be any, I mean, if you do this smoothly and efficiently, then you can place a duodenal stent, or you can go for another spot. In some places, people resheath the misdeployed axios. That can be done, and find another spot. There are other salvage strategies that are not as reproducible, which is like going into the peritoneal cavity. Remember, we have a nasobiliary drain here in this small bowel lumen. We can instill contrast and methylene blue. Under fluoro, we can make sure this is the target loop that we missed. So we can place a wire, and we can bridge with another lumen opposing metal stent. With the distal flange is deployed under nodes and under fluoro. We can see that under fluoro, then pull back on the misdeployed initial axios. There are two axios here, one across the stomach, one across the small bowel. And by pulling back on the small bowel halfway through deployment, we can reestablish continuity. Some people can even do that with the same misdeployed stent if you resheath. But as I said, this is not to be attempted on your first 25 gastroenterostomy. So in summary, these are the 4 essential steps to safely create a US-guided gastroenterostomy. You need to distend the small bowel the most efficient way, short of the MB. The double balloon tube is a nasobiliary drain catheter at the TRIDES angle, at the initial jejunum, and then freehand intrachannel LAMS placement with backup strategies for misplacement. Thank you very much for your attention.
So I request chairperson to maintain the program on time.
Right.
Dr. Miranda has overshooted to keep the on timing. We can take the question answer by email and we can proceed with the second, with the third speaker. Is a request to the chairperson, please.
Sure. So the last part of this session is a talk on EUS evaluation of pancreatic cyst by Dr. Pasavasti. And I request Dr. Pasavasti to come and present the talk. Thank you.
Hi. Hello, everyone. Nice to see you guys again virtually. And I like to make sure that I share my screen okay. So can you guys hear me?
Yes.
You can hear me okay? Okay, good. And you can see my slides?
Yes.
Okay, very good. First of all, I'd like to thank Dr. Puri and the organizing committee for the opportunity to be a part of this EUS Summit 2020. And today I will be speaking on EUS evaluation of the pancreatic cyst. The pancreatic cystic lesions can be neoplastic and non-neoplastic. Among the cystic neoplasm, it is important to differentiate those with malignant potential, including mucin-producing cysts, such as MCN or IPMN, and the cystic degeneration in a solid neoplasm, like SPAN or cystic pancreatic net. The currently available diagnostic tools include CT scan, MRI, MRCP, conventional EUS, plus minus contrast, enhanced EUS. EUS FNA offers a means to perform cyst fluid analysis, assessing for biomarkers and molecular analysis. Over the years, advanced techniques have been developed through EUS, for example, real-time histology like probe-based confocal laser endomicroscopy, microforceps biopsy, and brush cytology. Here are some typical EUS findings of the serous cystadenoma. These are usually multilocular microcystic lesions known as honeycomb appearance. Oligocystic variant can be seen. These usually have no connection to main pancreatic duct. Mucinous cystadenoma usually are macrocystic and can be uni or multilocular. What about IPMN? IPMNs are usually multilocular with pancreatic duct connection. They may have grape-like appearance like this. Dilated main pancreatic duct like this can be seen in main pancreatic duct, main duct IPMN. Also that you can see some solid component as well if the lesion turns into malignancy. Here's also an example of a SPAN or solid pseudopapillary tumor, which has a mixed solids and cystic component in a well-circumscribed border. What about PNET? We know that about 18% of pancreatic net have cystic component as demonstrated here. So we might want to keep this in mind in terms of differential diagnosis when we see this type of lesion. Besides from looking for classic findings of the EUS for each lesion, concerning features should be assessed. Studies have shown that enhanced solid component and main pancreatic duct of more than 10 millimeters are considered high-risk stigmata. Worrisome features include cysts of more than 3 centimeters or thick and enhanced cyst wall, non-enhanced mural nodule or papillary projection, main pancreatic duct of 5 to 9 millimeters, lymphadenopathy, and abrupt change of pancreatic duct size with distal pancreatic atrophy. When indicated, FNA can be performed for cyst fluid analysis, and CEA is the most helpful biomarker to differentiate mucin from non-mucinous lesion. Over the years, more advanced techniques have been developed, including cis-wall puncture, brushing, and targeting focal nodules. The techniques of biopsies and FNA have been described by Professor Wang earlier. For my talk, though, today, I would focus a bit more on the needle-based confocal endomicroscopy and through the needle microbiopsy. Classification of EUS confocal findings in pancreatic cyst have been established. Epithelial patterns and vascular patterns have been described. To me, I'm not an expert in this field of the confocal endomicroscopy, I have to say, but I think that the pattern that is the most easiest to learn and to recognize is the papilla and epithelial bands, which are suggestive of IPMN or MCN, and the fern-like pattern, which is suggestive of serous cystadenoplasty. Serous cystadenoma. Other characteristics have been described, and I think this is going to take a little bit of learning curve. For example, I'm going to show you all these videos, which is a courtesy from my dear friend, Pradum Shai. This first video is showing you a papillary projection, which is indicative of IPMN. And this case is a dark band-like lesion, which is indicative of MCN. For this, though, you can't see anything. Everything looks very fuzzy and very confusing. This is a inflammatory cyst, which is pseudocyst. With this, I think you can see it's going to take a little bit of learning curve for this technology to be widely used in the future. What about the data? Many studies have been conducted to assess the diagnostic performance of confocal endomicroscopy. And as you can see here, that the diagnostic accuracy is reasonably good, ranging anywhere from 70 to 80% here. Also, a study has been performed to assess the ability to differentiate mucin versus non-mucinous lesion using confocal endomicroscopy compared to the cyst fluid CEA. And as you can see here that the confocal endomicroscopy has better diagnostic accuracy, better sensitivity and specificity compared to either CEA of more than 192 or cytology obtained from FNA. Furthermore, a prospective multi-center study demonstrated that the confocal endomicroscopy has a better diagnostic performance in terms of differentiating mucinous from non-mucinous lesion compared with CEA and EUS morphology alone. Furthermore, confocal endomicroscopy appears to be better in terms of diagnostic performance in differentiating benign versus pre-malignant cystic lesion when compared to fluid CEA and EUS morphology. So what's the current status of confocal at this point? Based on the currently available data, it seems that confocal has better accuracy in identifying mucinous cysts than cyst fluid CEA and cytology analysis. It provides a better diagnostic performance than EUS morphology alone. It also has the ability to identify high-grade dysplasia or cancer in IPMN using quantification of papillary epithelial width and darkness with high accuracy, which I did not show the data of this study. What about through the needle biopsy in pancreatic cystic lesion? You've heard about this earlier this morning, that there have been 3 meta-analyses assessing the technical success, sensitivity, specificity, accuracy, and adverse events of the needle biopsy. Overall, technical success is approaching 100% with a pool sensitivity of 82 to 88%. Specificity is quite good, more than 95%, with an overall diagnostic accuracy ranging anywhere from 30 to 86%. An adverse event is about 5 to 10%. What else do we learn from these three meta-analyses? It appears that the through the needle biopsy has a better diagnostic accuracy than FNA cytology, also better tissue adequacy. This is a study that was conducted by Professor Willman Group. You have heard about this study a couple of times already today. This is one of the landmark study assessing clinical impact of the through the needle microbiopsy in patients with pancreatic cyst. This was a prospective study of 101 patients with a technical success of 94%. Based on the results of this study, using the through the needle microbiopsy would change clinical management in about 12% of the patients. It provides higher specific cyst diagnosis compared to FNA cytology alone. The adverse event, however, is about 10%, including 1 death. Furthermore, a recently published study just this year, last year, assessing the impact of EUS-guided microforceps biopsy sampling and the confocal endomicroscopy on the diagnostic yield and clinical management of pancreatic cystic lesion. As you can see this from this figure here, comparing with FNA cytology alone and composite standard, meaning clinical EUS morphology and cytology, microforceps biopsy and confocal endomicroscopy, they're both superior to composite standard using clinical EUS morphology and cytology. However, when we combine the composite standard and microforceps and composite standard with confocal and combine everything together and compare to each one of these together, it seems like there is a trend that the more techniques you use, the better yield you get, but the difference is not yet significant. So after listening to all of this, where does EUS stand in the evaluation algorithm of pancreatic cystic neoplasms? If we all believe in guidelines, you'll see that there are so many guidelines that have been published over the years, almost 10 years ago now, by the International Association of Pancreas, the American Guidelines, the ESGE, and most recently by the European Study Group on Cystic Tumors of the Pancreas. I'm only going to show you the aspect of EUS in the evaluation of pancreatic cystic lesions that I extracted from these guidelines. You can see the variations of recommendations. For example, the IAP would suggest to do EUS with a cyst of less than 3 centimeters with worrisome features, or a cyst of more than 3 centimeters without worrisome features, or to do the EUS if the EUS would differentiate IPMN from SEN. The American guidelines said to do EUS in cysts with at least 2 high-risk features. The ESGE said that you would only need to do EUS FNA if the results would change the treatment. If you do the FNA, then try to direct wall puncture, and you may consider sending KRAS mutation in selected cases. Other biomarkers, confocal lasers, endomicroscopy not recommended outside clinical trial. Having said that, though, these guidelines were released in 2017, but the data that I just showed you, that those just came out after these guidelines. For the European study, the guidelines recommend doing EUS if the clinical or radiological features of concern identified during initial evaluation or follow-up. They also recommend using contrast-enhanced EUS to assess a mirror nodule. FNA should only be done only if the results would change the treatment decision. Cisfluid CEA combined with cytology or KRAS GNAS may be considered. Brush cytology, forceps biopsy, not recommended due to lack of evidence. As you can see here, there's so many variations of the indications for EUS from different guidelines. So this study was conducted to determine when the EUS would change management for patients with pancreatic cystic neoplasm. This was a retrospective study of over 300 patients. And based on this study, it appears that EUS would change management when CT scan shows cysts of more than 4 centimeters or cysts of more than 3 centimeters, and associated solid component was seen with a pretty good odds ratio. Also, patient characteristics, including age of less than 50, male, 10 pack years smoking, were associated with EUS, associated with EUS change in management, meaning EUS should be performed when specific high-risk factors like cyst size or associated solid component with support from high-risk patient characteristic like male, age of less than 50, history of smoking, rather than the accumulation of multiple high-risk factors as suggested by the guidelines. So basically, in the real world, people are individualize the guidelines, which I think that's what we do in our practice as well.
Dr. Pasavadi, you may have to.
With that, I'd like to conclude that EUS is an adjunct diagnostic tool. EUS morphology alone is not enough. Probe-based confocal and through the needle biopsy may improve diagnostic and can be used in selected cases. And EUS tissue acquisition should be performed when the results would change the management. With that, I'd like to thank you very much for your attention.
Thank you very much for that wonderful synopsis of what we can do for cysts. And I think confocal microscopy is probably not available that widely, but the fine needle, the mini biopsy forceps are now available relatively easily and can easily be incorporated. So any questions, audience? Yeah, Dr. Kunal Das had a question.
No, I would like to congratulate both Miranda and Nothali for excellent presentations. One question to Dr. Miranda, that what is the, in which, are there any cases which you will not try US guided GE, or this has become the procedure of choice in all cases of GE obstruction?
Yeah, that's that question. That's a very interesting question. Because like everyone else, initially we were only using EUS guided gastroenterostomy in very extreme cases where either a duodenal stent could not be placed because the guidewire would not go through usually a third duodenal stricture, or because the stent was in place but there was ingrowth, angulation, or the stent wouldn't open. But as we gradually became confident with the procedure and it became standardized, because as I've tried to illustrate in the beginning, there were all different ways to try and do the same thing. But now it's become pretty much streamlined. So we use it routinely. We are not placing any duodenal stents anymore, unless there is some anatomical circumstances. You would say linitis plastica of the stomach that would, is the antrum pylorus that prevent gastroenterostomy, but that is very rare. Almost every patient that needs palliation for gastric outlet obstruction can be treated by EUS gastroenterostomy in a very reproducible, safe, and fast way. This is really under 20-25 minutes. Even the fellows are doing this. We did 3 cases last week. We have another 2 more scheduled for next week. So this has become routine. As I said, the advanced fellow is doing it now. And it was not like that 3 years ago. So it's moving very fast, very rapidly. And we're conducting now an international study precisely to establish what are the timeline for each procedural step, what are the potential difficulties. And from my experience during training courses in animal courses, this is much easier than choledochondroduodenostomy, than gallbladder drainage, and of course than hepatogastrostomy. We just don't know it yet. I mean, us, not us in Valladolid, we know it, but we're the privileged few who know this. By us, I mean the EUS community. Everybody is thinking of this like, wow, this is crazy, because I saw someone at this live course go into the peritoneum, try to do node salvage. Well, that was me 3 years ago. I mean, me or this, but now this is, as I said, becoming, all the pieces are coming into place very fast.
Thank you very much.
Thank you.
And I think we are up for time now, so we close the session here. Very interesting talks, and thank you, Dr. Miranda, Dr. Pasavadi, and Dr. Dheer, for making this a very interesting sessions. Back to the main desk.
Thank you so much, sir, for this wonderful session.